If you've been told you have shoulder instability, or you feel your shoulder could give way, slip, or it just doesn't feel secure, then this video is for you. Today we're going to cover why your shoulder feels unstable, the types of shoulder instability, which exercises can help, which movements to avoid, and whether surgery is an option for you. Plus, we'll look at the best way to rebuild strength, confidence, and stability. Now, this is going to be a detailed guide, so make sure you save this video and you're subscribed to the Physio channel. So what actually gives your shoulder its stability? Well, your shoulder stability comes from three key things working together. Firstly, we have the ligaments and joint capsule. Then we have the shape and fit of the bones. It's a ball and socket joint. And then the action of the surrounding muscles. If one or more of these systems struggle, the shoulder can feel loose or unstable and, of course, painful. One of the first questions that I ask patients is whether there's been a dislocation or not, because the mechanism can make a big difference to your diagnosis and recovery. Here, for example, is an image of a dislocated shoulder. Even once your shoulder has been put back in place, it's very common to feel instability afterwards. But you don't have to dislocate your shoulder to develop shoulder instability. There are other possible reasons. You may have been born with different joint shapes or structural variations, or you may have poor muscle coordination, something that us physios call muscle patterning. So if you think you have shoulder instability or someone has told you that you do, then stay with me because I'm going to take you through everything you need to know. Next, let's talk about the joint itself. Your shoulder joint is a classic ball and socket joint. If the socket is unusually small or angled differently, this can make the shoulder less stable and increase the risk of a dislocation. And we call this shoulder dysplasia. Now, around the joint, you've got a cartilage rim, ligaments, a joint capsule, tendons, and muscles. All of these structures work together to give your shoulder strength while allowing a huge range of motion. And it's worth remembering how important this shoulder joint is. It lets you reach up to cupboards, drive, cycle, wave to somebody, pick things up, and do many of the activities that you probably don't even think about until your shoulder stops working well. And when that happens, it can really get you down. So I hope this video helps you understand what's going on with your shoulder and what you can do to help yourself. Now, there are three types of shoulder instability, and understanding them makes everything clearer. The first type is traumatic structural instability. Now, this is your classic dislocation, often caused by a fall onto an outstretched hand, and we call this a foosh. Yes, that is a real term. These cases involve structural damage to the joint. The next type is non-traumatic structural instability. Now, this happens when the shoulder has an unusual structure, like a shallow or differently angled socket. Nothing dramatic or traumatic needs to happen for the shoulder to feel unstable. And then the third type is non-structural muscle patterning instability. Bit of a mouthful. Here, the muscles aren't coordinating well, and because the shoulder relies heavily on muscle control, poor muscle patterning can make the joint feel unstable, even when the structures are completely normal. So these are the three types of instability. They often overlap and are typically presented as a triangle, like the one showing on the screen here. So who is most likely to suffer from a shoulder dislocation? Well, anyone can dislocate a shoulder, but it's most common in young men in contact sports and in women over 70 after a fall. Now, after a dislocation, the risk of it happening again is higher, especially in the first 2 years and in younger people. In many cases, structural damage also occurs, such as a Bankart lesion, a Hill-Sachs lesion, or potentially a greater tuberosity fracture. Nerve irritation can also happen and can take several weeks to recover. Interestingly, having structural damage doesn't always increase the risk of a re-dislocation. People at higher risk of re-dislocation include those who work overhead, perform heavy physical work, and those who have a positive apprehension test 6 weeks after the first dislocation. And I will be showing you how to do this test. People who avoid movement due to a fear of pain are also at higher risk. Now, there's a risk prediction tool called the PRIS tool, and I'll link this under the video if you're watching us here on YouTube. Now, before we look at tests and exercises, it's worth acknowledging that living with shoulder instability can negatively affect your mood and confidence. In fact, Winston Churchill himself actually struggled with it. He described his shoulder problem as a terrible liability and it left him low and unhappy. So pain, fear, and uncertainty about movement can make this condition feel worse. So if this sounds familiar to you, then make sure you mention a low mood or anxiety to your physio or doctor, because these things matter when it comes to your treatment. Next, we're going to look at the typical signs and symptoms. Most people with shoulder instability describe pain spreading around the joint or pain down the front of the shoulder, also a feeling of looseness or slipping, and apprehension in end range positions such as abduction and external rotation. Muscle fatigue with repetitive use is also common. Most instability cases are at the front of the shoulder and are related to an earlier dislocation. But of course, instability can occur without any previous dislocations, and we mentioned this earlier in the video. One less common cause is hypermobility, and there's a simple 5-question screen that you can use to check for this. This screen is linked below the video if you're watching us here on YouTube. Now, you can also cause shoulder instability through repetitive overhead activity, either in work or with sports. In the clinic, one of the most important tests we use is the Apprehension Test. To perform the test, bring the arm out to 90 degrees and then externally rotate the arm whilst supporting under the elbow. If apprehension is felt towards the end or at end of range, then this indicates instability of the shoulder. It doesn't matter whether they feel pain or not, it is the feeling or report of apprehension, which they may communicate with you or you may see in their facial expression. Now, if I stabilize over the front of the shoulder, and before I do that, I'll just carefully place my thigh under their elbow to stabilize the arm, stabilize over the front of the shoulder, and then externally rotate the arm. This increases the stability and it usually decreases the apprehension and any associated pain. Now, if that stabilization or relocation helps improve the movement, then that helps to clarify the diagnosis. Now, the proper apprehension test is designed to be done by a professional, but you may be able to do a version of it yourself. So lying on your back on a stable surface, bring your arm out by 90 degrees and then externally rotate your arm. If you feel any apprehension at or towards the end of range, that would indicate a positive test. If you then stabilize over the front of your shoulder using your opposite hand, that stabilization may reduce the apprehension or allow you to move further into that range of motion. If you do, that can help to clarify the diagnosis. Next, we'll look at imaging and if scans can help us when dealing with shoulder instability. An X-ray can help identify any glenoid bony defects, bony Bankart lesions, or a Hill-Sachs lesion. If surgeons need more detail, a CT scan is often done. For soft tissue injuries, MRI is the gold standard. But what if the scan says you have a rotator cuff tear? Well, rotator cuff tears are very common in adults, and the tear may have been there long before the dislocation. What matters most is your function. Weakness and a loss of movement matter more than the scan image alone. So always look at the signs, symptoms, and scan results together, not just the scans in isolation. Let's look at nerve irritation after a shoulder dislocation. The mildest form of nerve injury is neuropraxia. It's a temporary blockage of the nerve signaling, and the common symptoms include numbness, tingling, pain, and weakness. The axillary nerve is the most commonly affected, and the risk of nerve irritation increases if the dislocation was forceful or if it took a long time to relocate. A complete nerve disruption is extremely rare. Now, if you've irritated a nerve, recovery can take longer and your shoulder won't regain strength until the nerve recovers. So keep this in mind if you're going through your rehabilitation process at this time. If you're wondering whether you need surgery after a first-time dislocation, many people do very well with non-surgical rehabilitation, but the research tends to be more supportive of stabilization surgery for specific groups, including younger patients, sporting individuals, and those with clear structural damage, such as a Bankart lesion. Now, this doesn't mean that everybody in those groups I've just mentioned need surgery, just that in those groups, the evidence is a little bit stronger. So should you wear a sling following a dislocation? The answer is yes, but only briefly. The research suggests that using a sling for about 1 week, then weaning off it quickly after that. Wearing a sling for too long actually delays your recovery because you lose muscle, your confidence levels drop, and your shoulder can become stiffer. Now, you can take the sling off for short rehab sessions during that first week to do light movements and gentle isometrics. Now stay with me because we're going to dive into the shoulder exercises for instability. Just quickly, I want to mention SLAP lesions. A SLAP lesion stands for superior labral anterior to posterior tear. It can occur during a dislocation, and in athletic patients, surgery may be considered. But SLAP tears can also occur in people who do repetitive overhead activity. And surgery in these cases is less successful and can reduce the ability to return back to that overhead activity again. And before we get to the exercises, I just want to introduce the idea of non-traumatic shoulder instability. So if your instability comes from subluxations rather than dislocations, you are not causing harm to the shoulder. And in these cases, rehab has a very high success rate, and surgery is not usually needed. The key is building rotator cuff strength, muscle endurance, awareness of shoulder positioning, and understanding a safe, comfortable movement zone for your shoulder. Resting or avoiding movement will only make things worse, as it's only a very short-term solution. Instability and pain can also increase anxiety, as we mentioned earlier, which makes the condition feel worse. So make sure you're honest with your physio if you're suffering from any of these psychological side effects of having shoulder instability. Now, as we dive into the exercises, these can help with instability that's caused by a dislocation and also instability that is not caused by a dislocation. So have a go at these exercises coming up and let us know in the comments which ones work best for you. Of course, this is an educational video and should not replace medical advice, so please make sure you see your doctor, physio or rehab professional if you're dealing with shoulder instability. Let's get started. I'm now going to take you through a series of rehabilitation exercises. We're going to start with 0 to 4 weeks. So for the first week, you're going to wear a sling, not at night, but during the day, and take it off 2 or 3 times during the day to do some gentle range of motion and static muscle contraction exercises. After you've worn the sling for 1 week, start to wean yourself off it as quickly as possible. For the first exercise, take a flexible strap or band or a broom handle, have your elbows bent, and then row that from side to side so that your shoulders are rotating in a comfortable range of motion. When you first do this, you might just have a small range of motion like this, but over the course of the first 4 weeks, your range of motion should gradually increase. For the next exercise, straighten your arms up above your chest and then lift the band up over your head within a comfortable range. For the first couple of weeks, you probably won't move that far, but into weeks 3 to 4, see if you can go a little bit further. And for the next exercise, sit next to a flat surface, place your hand on something that will slide along that surface and perform some gentle range of motion reaching exercises, which will open up the shoulder and start to re-establish that range of motion. For the first couple of weeks, your movement might be quite limited, but into weeks 3 to 4, you should hopefully be able to stretch a little bit further. Now in this first phase, it's also recommended that you start some early muscle contraction exercises, and these can be done initially without any movement. So just have your arm by your side with your elbow bent at 90 degrees and simply provide a counter force with your opposite arm and then push in against your hand. So I'm pushing this way but blocking it with this hand, and you can push in for a period of time, let's say minimum of 6 seconds. And then you push the opposite way, so you're going to be pushing out that way, but blocking it with this hand. Once again, pushing for 6 seconds. And you don't have to push with maximal effort, especially if that's uncomfortable. You could just push with 50, 60, 70% effort, for example. Then you can push forwards, again, blocking it with this hand, and pushing back, blocking it with this hand, which will then go under the elbow, and then push back like so. So that's the 4 directions: in, out, forwards and back, with 6 seconds for each 1. I'm going to show you 2 more common exercises which are recommended for those early stages after a dislocation. The first one is the belly press. So as the name suggests, just press your hand into your belly and push in. That's an isometric contraction. And with the arm in this position, it'll have a slightly different activation of the rotator cuff muscles. Now there's the opposite to that, and that's the lift off behind the back. For this one, it's recommended that you lie on your front. Place your hand behind your back as long as that's comfortable to do so. If it isn't, then don't do it. Place the hand on the small of your back there, and then the idea is that you lift the hand off away from your back and hold that for a few seconds. And that is the prone lift off. Don't do that exercise if it causes undue pain or any particular apprehension. Moving on, and we're still in that first phase, that first 4 weeks. You want to get the shoulder blades moving and all of the muscles around there. So with your arms by your side, it doesn't matter whether they're up here or down here, you pull your shoulder blades back, pulling them together so that they're squeezing together, and then do the opposite so that your shoulders are coming forwards, and then move between those 2 ranges. So fully forwards and fully back. Then up and down, so bring your shoulders up as high as they will go, and then drop them down and repeat that movement. And then the third movement is circles. So circle backwards and circle forwards. And you can do those 3 movements together. So forward and back is 1, up and down is 2, and circles is 3. Doing those 2 or 3 times a day will keep good mobility and coordination around your shoulder blades and that important scapulothoracic joint. It makes sense to do both sides at the same time, as this will help with your general coordination. Now, moving on. Just a quick tip for you, doing those forward and back scapular exercises whilst lying down can add a little bit of extra resistance and make the exercise a bit more effective. Okay, now we're going to move on to the second phase, or the post-acute phase. This is typically after about 4 weeks, and the inflammation in or around your shoulder would have significantly subsided, hopefully, as would have the pain as well. And this means we can then progress on to some more advanced exercises to really help to strengthen and stabilize your shoulder. So now we can follow the general exercise principles, and we're going to aim to do these exercises most days, certainly 3 to 5 days per week. We're not going to be doing anything excessively heavy. It's more about repetition and the quality and control of the movements. So I'm going to show you the exercises just now and let you have a go. Remember to make sure you get some professional guidance as you go through this video, especially if you experience any pain or upsets to the plan. For the first exercise, take a very light weight that you can hold. Even a 1 kilogram dumbbell will probably be plenty. Lie on your back on a stable surface and bring your arm out to the side at 90 degrees if possible. From here, and from the arm in this neutral position, start to rotate your arm back into that external rotation position. Being careful that you move within a comfortable range, and stop short of any apprehension if you feel that at all as you move further into the range. What you can do here is to start with some static exercises. So go into the external rotation position, find a comfortable position, and then hold it there for 10 seconds. After that, return back to neutral. And then if you are ready, go back and hold that again for 10 seconds. Once you've established this movement and the control and you're comfortable, you can then work more on dynamic movement, where you move as far as is comfortable and then back to neutral again, and repeat that exercise. Okay, so external rotation under control and back. Nice, slow, controlled movement. Now, if you're wondering how many repetitions to do, that's a difficult question to answer, because many of you will, of course, have different abilities and different levels of muscular endurance. So here is the answer. Make sure you do the exercise under control and within your comfortable movement range. After you've done a few, your arm will start to feel fatigued and the exercise will start to be harder to control. When that happens, that's enough. Stop, make a note of how many you've done, and then you can refer to that with future sessions to see how you are progressing. So you're counting to see how many repetitions you can do until you start to get fatigued, the movement becomes harder, and it's harder to control your arm. At that point, do make sure you stop. What you don't want to do is try and rotate your arm too far so that you're feeling a lot of apprehension or potentially pain. That might aggravate your shoulder and cause you to take longer to recover. And also you don't want to hold too heavy a weight or keep performing lots and lots of repetitions until your arm feels really, really fatigued and it's hard to bring the arm back in again. So don't overdo it. Just keep going until you feel a light level of fatigue and the movement starts to get a bit harder. That's enough. That will cause the adaptation that you need, and you can then progress on from there. With these exercises, as I mentioned, 3 to 5 times a week is plenty. If you push it too hard, you're going to need a bit more rest, but if you just perform them carefully, as I've shown you, you should be able to perform them 5 days a week. And I'd recommend performing the exercise in different positions, such as side lying here, where gravity is working against me as I move the arm up into external rotation. As you see, I'm using this arm to support underneath the upper arm, just to provide a bit of extra stability. And with this one, I find that you tend to get a faster onset of fatigue in the muscles, but you don't feel quite as much apprehension as you move into that end range. From this exercise, you can try a different one by bringing both arms up in front of you and then performing the same movement like so. This one is a little bit harder, so I'd recommend trying this after you've mastered the other two. And here are some alternative exercises using a resistance band. So you can stand on the band, lift your arm out to your side, and then again perform that external rotation exercise. Paying attention to the control of your arm so that you don't start to perform compensatory movements. So like this, for example. But a classic exercise is to hold the band in the opposite arm, and then with the arm by the side, just perform a resisted rotation exercise like this. I'm now going to show you a series of Pilates exercises that you can add into your program. So the first one, lying on your front, arms by your side, and then squeeze your shoulder blades together and lift your hands off the floor or couch. Hold for a few seconds and down. And repeat that. Shoulder blades back, arms lift off and hold. Next, bring your arms up by the side of your head. Keep them raised off the floor or couch, and then raise them above your head and back down, making sure you're pulling your shoulder blades back so your hands stay off the floor or off the couch. Move within a comfortable range of motion, making sure you're keeping control of both arms at the same time. Next, we'll go into the full plank position. So you can start resting on your knees, taking your weight through straight arms, and then if that's comfortable and you feel strong enough to do so, then lift your knees off the couch so that you're in a full plank or press up position. Hold for as long as is comfortable and down. What you can also do from this position is gently move forward, back, and side to side, so that you're taking an increased amount of weight through your right arm and left arm. And then try that once again in the full plank position. So forward slightly, back and side to side. These are the exercises that are recommended after a first-time anterior traumatic shoulder dislocation. So anterior dislocations are the most common types. The exercises are designed for people that have had a dislocation, of course, followed by a relocation of that injury. And they're ideally suited for people that have had a first-time dislocation. If you're suffering from shoulder instability that's not linked to a dislocation, then many of these exercises will still help. It's really important to strengthen up those rotator cuff muscles, to also work on the muscular endurance, control, and to have an awareness of your safe and comfortable range of shoulder motion. If you work on that on a daily basis, it can really help to increase the feeling of stability, improve your confidence, and hopefully reduce shoulder pain. Now, for some people with ongoing shoulder instability, there's a couple of key muscles which can often be tight and cause problems, and they are the pectoralis major and the latissimus dorsi. So stretching or massaging these can help with the rehabilitation and improvement of shoulder function. Now, there is also some evidence that taping can help with shoulder instability because it improves the sensory feedback around the joint, which can help to improve proprioception. So that brings us to the end of this video. Shoulder instability can be really problematic, but I hope there's enough information within this video to help you. Remember, it is an educational video, and if you are struggling at all, do make sure you get some professional medical advice. If this video is helpful, please do consider sharing it with somebody else you know. I'll put on the screen here, if you're watching on YouTube, some other helpful shoulder pain related videos. You've been watching the Physio channel. My name's Daniel Lawrence. Thanks for watching.